pathological diagnosis of bone sarcoma. Dr. Munir Ahmed is molecular biologist. As you know, bone sarcoma are rare and exhibit about or up to 20 histological types in WHO 2020. Pathological diagnosis must be based on WHO classification 2020 by expert pathologists and use, if necessary, ancillary investigation. As you know, treatment strategy, surgical resection is the mainstay as the curable treatment for bone sarcoma. And since 1917, chemotherapy has provided improvement in treatment and prognosis for osteosarcoma and Ewing sarcoma. But at year 2000, these results for chemotherapy have been in plateau, and actually with molecular biology, we hope that classification, diagnosis, treatment, and prognosis will be changes. Practical approach for bone sarcoma are based on multidisciplinary groups consisting orthopedic surgeon, radiologist, pathologist, molecular biologist, oncologist, and radiotherapist. This multidisciplinary group is essential for the diagnosis and treatment.
Thank you, Dr. Jlidi. Good morning, everyone. I will talk about the molecular abnormality in solid tumors. To simplify, we can divide these abnormalities in two groups. The first one is by gain of function and its oncogene activation, by translocation, by amplification, or by point mutation. In the other hand, we have the loss of function, and it's by loss of tumor suppressor gene, by deletion, by loss of function by mutation, or by hypermethylation. These can increasingly be detected by immunostaining. Briefly, molecular techniques. As you know, the karyotype was the first analysis in genetic in the field of cytogenetic. Fluorescent in situ hybridization, or FISH, was developed in the field of molecular cytogenetics. From RNA, we can detect gene rearrangement by RT-PCR, and next generation sequencing, or NGS, it's a powerful technology using reads of multiple reactions in the same time. From DNA to protein, we have molecular immunohistochemistry. The use of frozen tumor tissue is ideal, but not often used in Tunisia. And the EDTA decalcification is suitable for formalin-fixing tumor tissue.
As you see, this molecular biology is very important, but also very expensive. And now,
just a few words about liquid biopsy, because it's very important. The tumor releases in the blood of the patient cells, fragments of DNA, of RNA, and exosome. These elements are used for genetic analysis. Liquid biopsy is simple and non-invasive alternative to surgical biopsy, but liquid biopsy will complement the tissue biopsy, allowing more patients to be tested. The liquid biopsy is also used to control the evolution.
This method of liquid biopsy is used mainly for Ewing sarcoma, or tumors of Ewing family. These methods of molecular biology are expensive, and now many markers in immunohistochemistry surrogate this problem, like G34W for giant cell tumor of bone, MDM2 CDK4 for low-grade osteosarcoma, NKX22 for Ewing sarcoma, NKX31 for mesenchymal chondrosarcoma, and SMARCB1 for poorly differentiated chordoma. Osteosarcoma are the most frequent primary bone sarcoma. They represent in USA about 5 per million. They have two peak incidents. The first during puberty, mainly on metaphysis of long bones in knee. In older patient, these osteosarcoma are located in axial skeleton and craniofacial bones associated to Paget's disease or radiation. High-grade osteosarcoma patients frequently develop long metastases. These metastases followed after long by distant bones. There are many subtypes of osteosarcoma. Central high-grade osteosarcoma represent up to 90%. These osteosarcoma are graded, have grading dependent of location. In medulla, there are low-grade central osteosarcoma or high-grade central osteosarcoma. And in surface, there are parosteal osteosarcoma, which is low-grade, periosteal osteosarcoma, which is malignant osteosarcoma, and high-grade surface osteosarcoma. Cytogenetics for osteosarcoma.
The high-grade osteosarcoma is a prototypical example of primary bone tumor with complex genomics. In the karyotype, we have very complex abnormalities, and in the sequence analysis, we have somatic point mutation and a multiple alteration of copy numbers. The most common mutation is in TP53 genes, but it's not specific to be used in the diagnosis.
Low-grade osteosarcoma represent about 5% of osteosarcoma at older age after 25 years. They have slow growth and have excellent prognosis, about 90% survival 5 years. With complete rejection, they rarely metastases and about 4%. And we have central low-grade osteosarcoma and high-grade and parosteal low-grade osteosarcoma. Low-grade osteosarcoma,
cytogenetics. Low-grade osteosarcoma is an exception in the group of osteosarcoma. These subtypes display a less complex genomics. In the karyotype, we have a recurrent abnormality in the form of ring chromosome containing an amplified material from chromosome 12, Q13, Q15, and this marker containing an amplified genes involved in tumorigenesis, including MDM2. We have a low frequency of TP53 mutation with an excellent prognosis, and they differentiated in 10 to 36%.
In this case, a male 21 years old have osteolytic lesion of distal femur with pathological fracture. The diagnosis was no ossifying fibroma, and then the patient was treated surgically. But 4 years later, there is aggressive recurrence of this lesion, and in core biopsy, the diagnosis was high-grade osteosarcoma, and when we do the immunostaining for MDM2, many cells are positive for this marker, and the diagnosis was dedifferentiated low-grade osteosarcoma. This dedifferentiated low-grade osteosarcoma has comparable prognosis as conventional osteosarcoma with 40% of metastases. Chondrosarcoma are classified as primary or secondary chondrosarcoma. Primary are about 90%, and these primary chondrosarcoma are mainly central primary chondrosarcoma, which may be conventional in 90%, dedifferentiated in 8%, clear cell in 4%, and mesenchymal in 1%. But with these cartilaginous tumors, we have in pathology many problems for the diagnosis, mainly for the low-grade chondrosarcoma. And we have to, for the distinction between grade 1 chondrosarcoma and enchondroma, when we have these microscopic features like permeative lesion in the top, which is characteristic of chondrosarcoma, or entrapment of lobular cartilaginous lesion, which is characteristic with enchondroma, there is no problem for the diagnosis. But these microscopic features are rarely present in biopsy, and then we must refer to answer at this question, is the lesion growing with correlation with clinical and radiological follow-up for stable enchondroma every 6 months for the first year, and then annually at least 3 years at total follow-up. We need for the diagnosis to obtain adequate biopsy material, and need also clinical and radiological guidance. The second problem is the distinction between chondrosarcoma and chondroblastic osteosarcoma. As you see in the microscopic features top, there is peripheral condensation of the cell tumors at the periphery of the cartilaginous lobule, and this feature is characteristic of chondroblastic osteosarcoma. But in biopsy, there may be a sparse matrice osseous in the tumor, and we can have only the cartilaginous component in the biopsy, and then the confusion with between chondroblastic osteosarcoma and chondrosarcoma is frequent. And in this situation,
the mutation of IDH1 and IDH2 in chondrosarcoma is present in more than 50% of cases, and it's very helpful to distinguish between the two types.
For the low-grade chondrosarcoma, WHO 2020 has provided distinction between low-grade chondrosarcoma in appendicular skeleton and low-grade chondrosarcoma in axial skeleton. Now, in appendicular skeleton, we must don't use the term grade 1 chondrosarcoma, but we use donc atypical cartilaginous tumor, and the treatment must be curettage for the lesion, but in axial skeleton, the diagnosis must be chondrosarcoma grade 1, and the treatment surgically must be rejection. The differentiated chondrosarcoma are about 10% of chondrosarcoma and represent about 50% from a secondary chondrosarcoma. Most patients are older. There are similar sites as conventional chondrosarcoma. IDH1 and IDH2 mutation in chondrosarcoma are present in this tumor, and histologically, this tumor is characterized by big compartment microscopy with one compartment as well-differentiated chondrosarcoma, and the second component is high-grade sarcoma. These tumors are very aggressive locally and have extremely high metastatic rate. Clear cell chondrosarcoma have epiphyseal location in long bones like chondroblastoma or giant cell tumor of bone. They are well circumscribed and may have sclerotic border. In 50%, they have conventional chondrosarcoma or aneurysmal bone cyst in the tumor. And in this clear cell chondrosarcoma, IDH1 and 2 mutation are not found. Mesenchymal chondrosarcoma are rare. They have predilection for craniofacial bones, spine, ribs. They may be extraskeletal in 32% or in meninges. They have histologically this microscopic bimorphism with one component which is well-differentiated chondrosarcoma, top left in the feature, and the second component is round cell sarcoma like Ewing sarcoma or hemangiopericytoma. Now, with immunohistochemistry, we have an excellent marker which is specific for this tumor. This marker is NKX31. As you see here, all the cells are positive for this marker, and the diagnosis of chondrosarcoma is final.
The expanded family of Ewing sarcoma and related tumors. The genetic hallmark of classic Ewing sarcoma is a fusion between EWSR1 or FUS genes with a member of ATS transcription factor family. In contrast, the fusion between EWSR1 and non-ATS, this group was designated until recently as Ewing-like sarcoma. This group was reclassified as a round cell sarcoma with EWSR1 non-ATS in the latest 2020 WHO classification. Moreover, the sarcoma with sick rearrangement or BCOR genetic alteration have been classified under the group of Ewing tumor family are now regarded as standalone pathologic entities. The group of PNET was excluded from this classification. Suivante. Ewing sarcoma. Ewing sarcoma, the definition is the presence of fusion between FET genes with ETS genes. The most common FET gene is EWSR1. The most common ETS gene is FLY1. And we have, in 85% of cases, translocation between chromosome 11 and chromosome 22 with a fusion between EWSR1 and FLY1. In 10% of cases, we have translocation between 21 and 22 with fusion between EWSR1 and ERG. And anything else is less common. The image, we have normal cells, and in the other hand, we have a typical image of Ewing sarcoma.
And in immunohistochemistry, for this round cell sarcoma, we have CD99 positive, but CD99 is not specific for Ewing sarcoma. And now we have two other markers, which are NKX22 and PAX7. And now, when we have these three markers positive, we are certainly with diagnosis of Ewing sarcoma. We don't have need to molecular biology.
Other group, round cell sarcoma with EWSR1 non-ATS fusion, it's quite rare, but the subtypes of EWSR1 and FAT-C2 fusion, it's important to recognize this form because they have different morphology. They present pattern more aggressive, and it's important to recognize because they respond poorly to Ewing sarcoma regimens. These sarcoma present genetic instability, known to be involved in drug resistance and high proliferation. BCOR family of tumor. The genetic abnormality in this sarcoma is a paracentric inversion in the short arm of chromosome X, resulting in the fusion between two genes nearby, BCOR and CCMB3, and leading to the overexpression of gene CCMB3.
Conventional chordoma are malignant tumor of notochord origin that usually arise in axial skeleton and midline skull base. At adult age, they are characterized in histology by these large cells, clear cells, which are physalliferous cells, and stains in immunohistochemistry for keratins and brachyury. Brachyury is specific for this tumor. They metastasis in about 40%. 40%, usually in late natural history, mostly after local recurrence. They have 5-year survival up to 60 to 70%. The differentiated chordoma are like conventional chordoma in location and in age also, but have predilection for these differentiated chordoma to spine. They have characteristic microscopic bimorphism with one component like conventional chordoma, top in the feature, left feature, and the second component is high-grade sarcoma. On the right, you see that brachyury, which is specific for this tumor, is present in conventional chordoma, but completely absent in high-grade sarcoma. These differentiated chordoma are resistant to chemotherapy, and wide rejection is associated with better prognosis. Poorly differentiated chordoma, unlike conventional chordoma, are described in children and young adults and have predilection for cleavage and cervical spine. They are characterized by poorly differentiated epithelioid to rhabdoid morphology. They stain like conventional chordoma, but the characteristic for this tumor is loss of expression of SMARCB1 or INI1. And this is characteristic of the diagnosis of poorly differentiated chordoma. This form of chordoma is highly aggressive of malignancy and have better prognosis after chemotherapy. Malignant giant cell tumor of bone may be primitive or secondary. Primitive malignant giant cell tumor of bone are always low to intermediate sarcoma, as you see in the feature top. You have giant cells and stromal tumors which present many atypia and mitotic rate elevated. And the characteristic for the diagnosis of this tumor is G34W expressed in stromal tumors. This is characteristic of giant cell tumor of bone. Secondary malignant giant cell tumor of bone are maybe post-radiotherapy with interval time about 8 years, or post-denosumab with interval time about 1 year. They are high-grade sarcoma with giant cells which are rare or were absent. And in this sarcoma, high-grade sarcoma, G34W is rarely expressed. To explain this distinction for malignant giant cell tumor of bone,
the model of evolution on conventional to malignant GCT, as you know, the benign form of GCT have a somatic mutation in the H33A gene, but the evolution to malignant form is still unknown. but the decreased expression of H3/3A and the increasing in the genomic complexity is in favor of that additional genetic alteration are responsible for the genesis of dedifferentiated malignant clone.
In conclusion, the diagnosis of bone tumors frequently poses challenges to pathologists and clinicians, and this reality is not surprising as the tumors are uncommon. Accurate diagnosis requires an integrated approach that assesses and correlates the clinical, radiological, histological, and molecular features of the neoplasm. In most instances, successful patient care is best accomplished when members of sarcoma multidisciplinary team collaborate to diagnose the treatment and decide diagnose the tumor and decide for treatment and prognosis. Work in progress. Thank you for your attention. And excuse us, we don't speak very well English. Have you a question?
So the next talk is actually by our radiologist all the way from Oxford via Zoom, and it's Dr. Karen Partington who's going to be joining us. And I would like to thank her for sparing time out of a very busy day she's having at the Royal College. And she's taken time out, and she actually agreed to cover both radiology talks on a short notice. Thank you, Karen. Can you hear us?
I can hear you. Can you hear me?
Yeah, we can hear you all right. The floor is yours.
So I'm going to cover both of the talks. The first part is a lot of the basic stuff that many of you will already know, but I'm just going to cover from basic and then go to some of the more advanced techniques that we do, but also some ways to utilize your radiologists that we do in Oxford. So I'm a MSK radiologist at the Nuffield Orthopaedic Centre, and one of my main interests is tumour, basically, both in the adult and the paediatric population. So I'm going to give you a little radiology tour. This is the basic tour. So the pros and cons of the imaging, basically. Where imaging can make the diagnosis. And some real tumour cases, the differentials we would be giving as a radiologist, and that allows you to have the discussions with the surgeons. So the imaging options I'm just going to do in this one are really just going to be briefly plain X-rays, MR particularly, ultrasound, which is an unused modality. Functional imaging is part of some of our more advanced stuff that we're doing, and I'll pick up on that on the next talk. So I'm not out to teach orthopedic surgeons how to look at X-rays. You're all actually exceptionally very good at them, actually. And as orthopedic surgeons, you actually understand the importance of a plain X-ray. A lot of the radiological diagnoses can actually be made on plain film. What we tend to find in a lot of our less specialist centres, they send us a lot of MRI, for example, and actually what all of us want more than anything is the plain film. The plain film clearly here shows a bone-forming tumour, therefore it's going to be an osteosarcoma. The MRI for these can look rather strange sometimes because bone and MRI bone formation is rather weird characteristics sometimes, but various things, particularly like bone-forming tumours, fibrous dysplasias, are much easier diagnosed on plain film. And when you have things that have got syndrome, so for example, looking for dedifferentiation in people with Mazur-Brow syndrome, so polycytic fibrous dysplasia and myxomas, it's actually very difficult on MRI scanning to find the one that's dedifferentiated. It's a lot easier on the plain films. I'm just going to do a bit of basic MRI. I'm not going to teach people physics. We all have different sequences for MRI, whether that be in the United Kingdom, centre to centre, or internationally. In essence, we all, though in MSK, are actually quite simple. We stick to mainly the same things. We stick to T1s, T2s sometimes, PD fat sats or STIRs. So basically, that's what we call the fat saturated fluid sensitive sequences. Gradient echo imaging, or it's called T2 star in other places. And then there's other things like giving gadolinium, contrast imaging, and more things like diffusion weighted imaging are coming out within tumours now. So the very, very basics is what I said. Stir is the thing that you'll notice that a lot of us will put straight up when we're doing the MDTs. It's what I call the elephant in the room. It's a hallelujah moment. It actually shows the abnormality really, really easily. So it's very sensitive, but actually it's not very specific, is the honest answer. Just because something is bright doesn't mean it's tumor. It just means it's bright on a fat-saturated fluid sensitive sequence. So although there's what looks like an extensive abnormality involving the whole of the lumbosacral spine, this is actually tuberculosis. So being bright is very sensitive, but it's not very specific. T2, again, fat and fluid. What's more interesting on a T2, actually, is not the bright, it's what's dark. Because actually, this is where you can make your radiological diagnoses, because there are only about 5 things that are actually dark on a T2. So things like fibrous tissue, so fibromatosis, calcification, flow voids that you get within vascular malformations, melanin within melanoma deposits. So it's actually the dark bit that's better. Conversely, same with a T1, it's great to show the bright stuff for fat. That helps us particularly in our lipomatous tumors, whether they are atypical or whether low-grade or high-grade liposarcomas, is to do with how much fat and how much atypia there is. And there are, again, very few things that are bright on T1. So things like subacute hemorrhage, again, it's useful that you can see that you can have an underlying tumor that's got hemorrhage within it. Again, melanin and contrast, of course. And you can see the issues with calcification, all these, sometimes they're bright, sometimes it's dark. It's actually a really difficult thing on MRI. So all these are the bright ones. So you'd think, well, if the elephant in the room is the stir, you see us all put it up, that it just makes the diagnosis. But you can't do anything in isolation. One image does not give me the answer. So whilst that stir is absolutely completely normal, the T1 is completely abnormal. Because the whole of the fat in the bone marrow has gone and you're completely filled with tumor. So this is your kind of multiple myelomatous disease, your prostate cancers, all of those kind of diffuse bone marrow. And then there's more other areas that we actually add in. We add them in to try and help make diagnoses. So although we use them in some of our common indications just for our day-to-day work, we do use this gradient echo imaging or T2 star, whatever the MR company wants to call it. It basically takes the magnetic field and it plays with the inhomogeneities about the magnet. So in other words, it makes artifacts in certain conditions. So all this darkness around here is all this blooming artifact. And you see that in certain conditions. One, a tenosynovial giant cell tumors with a tendon sheath, siderotic synovitises, and hemophilias. It also shows up micrometallic artifacts, and that's where the surgeon's gone in for his arthroscopy. So it also helps me knowing where people have been before. Ultrasound, we're a huge centre for ultrasound in Oxford. It is operator dependent, but it does have its roles in tumour as well. It's excellent for distinguishing fluid. So if you're looking for an epidermal cyst versus a tumour, an MRI scan signal characteristics are actually not going to give you the answer. The easiest test is actually going to be an ultrasound. Same with vascular malformations. One of the reasons we're doing ultrasound, even if we have the MRI, is to characterize them into low flow or high flow and to see whether things like sclerotherapy will be appropriate for them. It also is a lot easier to see superficial lipomas on ultrasound than it is on MRI sometimes. So all I'm going to do just for a few moments is just go through some of the cases that have come through ours. The diagnosis will have been touched on this morning, but it just gives you an idea how information matters. So, this is a typical case that can come through any of our MDTs with our large destructive iliac wing lesion. It's got this wide zone of transition. In other words, I can't draw a pencil around it. It's got soft tissue mass, but it's got this spiculated periosteal reaction. The honest answer is it could be a multitude of things to start with, from a metastasis, a plasmacytoma. People often forget about myeloma screens and myeloma, primary bone tumor, given the way the periosteal reaction is. And because of that circumferential soft tissue mass, lymphoma of bone is always a good guess. However, without more details of the age of the patient and actually sometimes a background history, you can't really narrow it down as much. If this patient was in their 20s, you'd very much be going down primary bone tumor lymphoma. If they're 80s, statistically, it'll be a metastasis or a myeloma. So there are always areas of where clinical information matters. I know they touched on these this morning. So you've got these subarticular lesions. So location is everything, as is the fact that this is a fused physis. So this is a skeletally mature patient. You often see them looking quite aggressive. You can see how thinned out the cortex is, but the cortex is actually still there. Interestingly, on MRI, it often looks like the cortex isn't there, and it's the plain film that really helps us. If this was unfused physes, obviously it would be a chondroblastoma as the most likely diagnosis in these cases. These we see an awful lot of being referred that people are worried about. These are always metaphyseal. They generally point away from the joint. They must have continuity with the marrow. If they don't, then they cannot be osteochondromas. There'll be something like BPOP, bizarre osteochondromatous proliferations. And on plain film and on MR, you get a varying amount of chondroid matrix, and it can look very, very worrying sometimes. One of the main reasons we're imaging these, or we want for the cartilage cap, whether that be ultrasound or MRI, but normally for the complications such as bursal formation and neural compression, we're often referred these as a de novo and then potentially investigate for hereditary multiple exostoses, particularly in our pediatric population. And again, one of these commonly comes through most people's MDTs or requests. It's cortical, it's pediatric. You can see this very thin lucency. It's a young patient. Interesting, on the plain film, even I can't decide whether it will be an osteoid osteoma or a stress fracture. MRI and osteoid is very useful. It shows us the degree of marrow edema, but sometimes you can actually miss the osteoid osteoma on them, which is why it's quite common to do both MRI and or CT as well. Certainly with those that you're following up or have ablated, that the nidus may have changed or decreased post-ablation, but the MRI will show you whether there's any ongoing marrow edema. So it is a dual imaging. Our increasing practice on chondroid lesions is very large. We get a tremendous number on both the plain film and on the MRI. And one of the main things we're always looking for is what we call these endosteal scalloping, to see whether it's starting to scallop the endosteum and start to breach through. Interesting from a radiology point of view, a lot of the time I don't have the history. I won't know if the patient has pain. I can measure the size of them and obviously the degree of scalloping. And that's when we do our hybrid technique. So that's when we tend to consider nuclear medicine scintigraphy particularly as well. So we commonly use the SPECT CTs for these. On the opposite side, of course, you've got these other very endosteal scalloping. You can see the cortex has completely gone. That implies this is quite an aggressive tumor. Red on PET scans is hot, which means it's incredibly high on an SUV. So this will be some form of primary bone tumor. And given the degree of scalloping and no new bone formation, the most likely will be something like a chondrosarcoma. These are generally one of our other imaging issues. These are the anterior tibial lesions with these narrow zone of transitions. You can see I could draw around it. You've got this thick sclerotic rim, which generally implies that something's been there for a while. It's slowly been growing. You can see the cortex though is expanded. So these are cortically based lesions in skeletally immature children, but in a specific location within the tibia. Imaging wise, you have three options between osteofibrous dysplasia, osteofibrous like adamantinomas and adamantinomas. And in essence, sometimes they're a bit of a spectrum. It's common that we would MRI these and common that we would actually gain a percutaneous biopsy as well. The other issues with imaging lots of things is when they've just fractured. Obviously, when you're looking for things that are benign versus malignant, you're looking for these soft tissue components, cortical breach, which is also complicated when you've got an acute fracture. And a lot of these are actually diagnosed on the plain film, where you've got this metaphyseal lesion. You've actually got this little fragment in the middle, which is a fallen fragment sign, which is, in other words, a unicameral bone cyst that's recently fractured. You'll notice the MRI there has no edema around it because we've waited for this fracture to heal excuse me, before we've done the MRI. So we've waited at least 4 weeks because we were happy on the plain film before we've imaged it so that we can confirm on the MRI. Even though these are benign, because they're commonly treated, we do MRI them. One of our other major works is within fluid level lesions. You see that they tend to settle where the patient scans. So many times the imaging you're looking for may be, for example, the axial imaging, because it will settle on it. The key with these, with lesions with fluid is making sure there's no soft tissue component, because actually there is quite a differential of fluid level lesions. And they do span from benign to malignant, from our primary aneurysmal bone cysts all the way to the telangiectatic osteosarcomas. You can see them in giant cell tumors of bone, and you can get them in chondroblastomas as well. The key is about the fluid levels with no soft tissue, which makes it an aneurysmal bone cyst. In a moment, I'll touch on some of our work that we're doing with these as routine practice rather than operating as well. I love plain films. I know the diagnosis looking at this rather than the MRI, which I suspect will have been even more complicated. There's actually more than one lesion here. It's got this slightly matte look to it, like someone's kind of painted the wall. And that's when people start banding this word ground glass matrix around. And as soon as people start saying that, then it's fibrous dysplasia. But it's common sometimes that you're getting more than one lesion. And that's when you really do need to consider the other syndromes, the McCune-Albrights, the Mazza-Browds. They are commonly presenting later. In our centre, we would routinely do a whole body MRI of a patient who's got a fibrous dysplasia lesion to look for polyostotic lesions. And again, we touched on the GRE sequences before. You see the blooming artifact. You can see that this is therefore going to be one of our differentials along the previously PVNS, now called tenosynovial giant cell tumor, or what we call a siderotic synovitis. So things like if it had a synovial hemangioma that has bled, or a history of haemophilia, that would change the diagnosis. We get a tremendous amount of tenosynovial giant cell tumors referred to us. And unfortunately, we get a tremendous amount of these referred. These very large lesions within the sacrum with tremendous bone destruction and neural compromise. The sheer size of it makes it unlikely to be a metastasis or a plasmacytoma. And given the fact of location and size, this will be a chordoma. There is other differentials, of course, and obviously it depends between all of these, whether they're going to the primary centre or to just the local metastasis versus plasmacytomas. And we talked earlier about low signal and how useful it can be. And when you get all this low signal stuff on T1s and STIRs, it tells you that it's got to be something fibrous normally. So whether it be fibrous within a tumour, so fibrosarcomas, or this where you get this brightness and darkness, which is basically what we see when we get fibromatosis. What you see on imaging with fibromatosis as they're on treatment, so for example with tamoxifen, you will see on the fluid sensitive sequences that the bright signal will change. It will become darker. In other words, it shows there's been a response to the treatment. And so we follow these up on MRI. And I'm talking to the converted orthopedic surgeons. One view is never enough. It's very difficult to tell where this lesion actually is, whether it's in the joints, whether it's in the soft tissues, whether it's projected over the bone or even coming off the bone. A second view would have absolutely helped because it depends on the location. On a joint-based pathology, you'll be thinking your synovial osteochondromatosis when you're thinking in the soft tissues. Obviously, the myositis ossificans, but obviously tumours that calcify, sometimes like synovial sarcomas, would be our worries. And not everything is tumour. This dorsal soft tissue mass is attached to the tendon. You'd assume that therefore the most likely diagnosis would always be a giant cell tumour of tumour of the tendon sheath. But it hasn't got any blooming that we talked about. It doesn't have these black blobs, and that's what you generally would see in a TGCT. And instead, again, it's the plain film that gives you the diagnosis when you see that it's actually got erosions on the metacarpal head. And therefore, randomly, this actually is going to be a rheumatoid nodule. Not everything, just because it's soft tissue mass, is actually a tumour. So before I touch on the more hybrid techniques, Most of our primary secondary tumours will always have a radiograph. If it's not been performed in another centre, we will always perform one. MRI, which image the above and below the joints. Staging, we use a tremendous amount of PET-CT for tumours that are very low grade or only metastatic potential to the chest, or so low grade, or a GCT will do CT of the chest. I use the words image-guided biopsy rather than specify ultrasound, CT, or fluoroscopy. It really is radiology dependent on what the capability is of the operator. We do a tremendous amount of intervention under ultrasound and fluoroscopy that a lot of other centres would do under CT. And just because something's benign, it doesn't mean it doesn't need further imaging. We will use imaging, both MRI to make the diagnosis. We will biopsy some of these lesions to prove the diagnosis, but also we'll use some functional imaging such as scintigraphy. We'll use whole body MR, like the one here, to make a larger field of diagnosis, so your HMEs, your MASA-brows, but also things like chronic recurrent multifocal osteomyelitis that's commonly referred as a potential tumour to us. The diagnosis can actually sometimes be made off the imaging without requiring a biopsy. So those are our most simple ones. I'm going to have to swap to the other one. Excuse me one moment as I just change things. And touch on the sexy stuff, as I call it. Functional imaging has taken off over a huge amount of years, and now is actually the mainstay of staging for not just bone and soft tissue sarcomas, but actually most primary tumours. I'll just mention a few areas where imaging helps within the soft tissue bone tumour work, a few of the cases where you can use your imaging, and also just how to utilise potentially your radiologists more, and what we do in Oxford for our team. When I was training, functional imaging was called spots and dots because it was just black blobs on a white screen. Now it's become much more hybrid. So you're talking about taking a combination of functional imaging, so metabolic information, and exceptional cross-sectional anatomy. And the idea is, with whatever tracer you're giving, that it demonstrates the abnormal metabolic activity at molecular level. Obviously, malignant cells have increased glucose utilization, and it's the FDG, we use an FDG PETs, is an analog of glucose. The rate of your FDG is proportional to their metabolic activity. So where do we use it? So we use it in our sarcoma and bone tumor stagings. We use it in lung cancers, head and neck, myeloma, lymphoma, melanoma, nearly every primary cancer now. It's useful for helping with indeterminate nodules. We use it in our bone tumor soft tissue work for response to treatment. We use it for surveillance, but we also actually use it highly for decision making, and it has changed a lot of the decisions that we've been doing and what the surgeons have decided to do. But there are always pitfalls. Just because something is bright and big and red here on this PET scan actually doesn't mean it is a tumour, because you can get uptake in certain areas because it's metabolic. So you can get areas of brown fat uptake. So you may see scans where it's around the shoulders and it's big and red, and that's just where brown fat stores. If the patient hasn't fasted for their scan, again, you can get uptake. The patient has to be compliant. They have to lie in a room for an hour or two to let their muscles settle. Obviously, PET isn't very useful if our tumour happens to have low metabolic activity. So a low metabolic activity tumour has a lower sensitivity on PET scan of demonstrating metastatic disease. And like I said, just because something's avid doesn't mean it isn't benign sometimes. Things like fibrodysplasia and hypernomas can be hot on PET-CT. And the colour doesn't always mean it's red, red hot. It's always important if you're doing these imaging or requesting this imaging, particularly to state if you want the legs or the arms completed. Routine practice for a PET-CT would actually just be the coverage you see here. So if you are requiring arms or legs, you do need to make sure that it's on the requests. We also use the hybrid technique of SPECT, so single photon emission CT. So it's a much more spatial information with basically bone scintigraphy. It's much less radiation than PET-CT, and it's more focused. So we're only scanning the bit that we need to scan. And one of our main areas for using that is, as we said before, within our chondroid lesions. So where we have maybe a small amount of endosteal scalloping or very little, but the patient may have pain. It would allow us to get an avidity to see whether this tumour is active or not, as to whether we watch and wait or whether we consider curettage. So where does all the imaging hybrid make a difference? It's quite common, unfortunately, to see that sometimes people do inadvertent tumour excisions in other hospitals. MRI will obviously show that you can see that there's some signal change within the subcutaneous fat. I could give it contrast, but it'll likely enhance, scar tissue will enhance inflammation post-op just as much as tumour will. So PET here is quite useful. It allows us to see whether we've defined any residual disease, and it allows us to decide whether the plans for re-excision or how large an excision area should be required and whether flaps will be needed. It also allows us to find the unknown or unexpected metastatic disease as well. We use it for response. So we have a PET CT at the top before and the one after. So it's an aggressive lesion, and you can see that the avidity is decreased. It shows us there's no distant disease, defines the extent, the response to treatment. It gives us an idea for amount of necrosis. And actually, the dots on the bottom in both femurs are actually showing the bone marrow response to chemotherapy or granulate GCSF factor. So it does pick up an awful lot of small metabolic level changes. We use it to define the extent, particularly the avidity, the SUV of tenosynovial giant cell tumours, particularly those that are going to be going on to medical treatment. It's a benign disease, but there is potentially systemic therapy, and it's one of our more difficult diseases to treat. It allows us to see a response to treatment, and we're increasingly using this. It's incredibly helpful in patients where there's diagnostic uncertainty as to patients with long-term conditions like neurofibromatosis, is there any dedifferentiation? It defines extent of disease, it gives us some SUV. We obviously monitor these patients for changes in size of lesions with MRIs. We do whole body work with them. And a change in size would obviously make you worry about dedifferentiating. But actually, it's sometimes not the biggest lesions that are the hottest and therefore the more worrying. You can see the same patient, his largest lesion within the chest actually is FDG negative, and therefore it is just a benign neurofibroma. It was the smaller ones that actually were the ones that were dedifferentiating. So it allows us to get a real overview on these much more complex patients. And it allows us to guide a biopsy. Sometimes with large lesions or lesions with necrosis, it's hard to know which area has the most potential malignant cells in it, so that I gain a diagnostic and not necrotic biopsy. If, for example, we've had a failed biopsy on a first attempt, the PET scan allows us to target the hottest and most avid metabolic area to increase our chances of getting a diagnostic sample and an overall representative sample of what actually the grade of this tumour actually is. This patient had an aggressive soft tissue sarcoma, had been resected multiple times. He had never actually had metastatic disease, but he kept having local recurrence and extensive recurrence. And the PET was able to show us that there was no distant disease, but it defined the extent and the fact that an R0 resection was going to be unlikely. But because of that, even though he had no systemic disease, it was felt best for palliative therapy. It's also incredibly helpful for the tumours that you can't feel, or the patients who've had flaps or have had multiple resections that actually clinically it's hard to feel if the lumpiness is anything or not. This lady was a routine follow-up with extensive resections with a flap. It was a non-palpable disease that was picked up. For these types of tumours, once we've image-guided biopsied them and made the diagnosis, it's quite common that our surgeons will ask us as radiologists to put a wire in these prior to theatre. So we'll insert a wire into the tumour under ultrasound that will hook the tumour, that then the patient goes to theatre on the day, so the surgeon can find the tumour. And it also finds the bits that you can't see. So the palpable disease in the vastus lateralis on the left, but there was non-palpable disease within a small lesion. So there actually was multifocal tumour in patients, which changes the approach to surgery and potential therapy. Any type of chondroid lesions, we are commonly, like I'm saying, using some form of functional imaging with them. And when we have these avidity, it allows us again to biopsy that one bit, particularly with chondroid lesions where we don't really like biopsying them because there can be diagnostic uncertainty of a grade in the pathology. So therefore we try to hit the most metabolic active area that allows us to overall get the most representative sample and help the pathologist in what grade it will be. So how can you utilise a radiologist better? Well, it does depend on your radiologist, but over the years there's definitely been an increasing need for percutaneous adult and paediatric MSK interventional work. We do a tremendous amount of bone soft tissue biopsies in children and adults, and we're increasingly taking on a lot of therapeutic procedures. We do a lot of work under general and non-general anaesthetic. Obviously, lots of things were impacted across the world with the COVID-19 pandemic, and as yourselves as surgeons, access to theatre. And thus, certainly in Oxford, the radiologist became even more important if we could do the procedures without requiring theatre time. So from our points of view, all of our ultrasound-guided soft tissue biopsies, we have a direct access clinics 2 days a week, plus slots out with that. They're aligned with our surgeon's clinic at the same time with a radiologist list literally down the corridor. We provide on a weekly basis at least 10 if not 12 ultrasound-guided soft tissue biopsy slots dedicated to the sarcoma group. They are marked by the surgeon if they want us to go in a certain approach, or they place the approach on the request form for us. In some of the children, we may use things like Entonox or Emla cream for gas and air, but increasingly we're just doing even paediatric biopsies, so anything from about age 9 upwards with just local anaesthetic. After lots of work with our pathologists, we take very large samples, so our soft tissue biopsies are all 14 gauge needles, and the majority of us will take at least 6 samples. We're increasingly now taking extra samples as well to send for whole genomic sequencings as well. But there are some pitfalls with that called the sex imaging on MR. On the MR, it looks like this is all soft tissue, but when you look at the plain film, a lot of this is actually bone-forming tumour. And that changes things when I have to take biopsies about what type of kit I might use and trying to visualize the needle tip in the middle of a lot of bone. But just because something is bone doesn't mean it has to be biopsied under things like CT. The majority of the time, we'll do a lot of these under ultrasound or even fluoroscopy. And fluoroscopic bone biopsies, yes, we do these with patients awake. We don't do them under general anaesthetic. We do also do them with children awake if it's felt that's appropriate. The children, again, we have the access to Entonox as well. And again, we take large samples. We take 11 gauge samples and try to take at least 2 to 3 samples. Commonly, we'll perform for single bone lesions, either for primary bone tumours or things like even CRMO if it's a single bone lesion with none others than a whole body MRI. But there's also therapeutic intervention that's increasingly undertaken by us. We do perform these under general anaesthetic to do the radiofrequency ablations. Between us as colleagues, there's no definite time or temperature in the literature actually that you should ablate these for. And increasingly over the years, we've actually upped the amount that we ablate for longer and increased the intensity and degrees that we use. Obviously, the issues we have is if it's close to cartilage or nerve, we decrease that because of the penumbra around it. Increasingly, we are serially ablating these rather than surgery, even in small digits, such as at the big toe, for example. So we're constantly using further ablations. Also, there's a huge amount of CT-guided sclerotherapy that we undertake for aneurysmal bone cysts. We do this in the routine practice. We also do it currently over in our other sister centre, that's the acute service. For example, the ABCs that present with cord compression, we can also perform a sclerotherapy there. So generally these are done again on a general anaesthetic, and they tend to require serial therapies. We are doing some of them not under CT, if we can do them under ultrasound as well. That obviates the need for a GA as well. We're doing a tremendous amount of these and a tremendous amount of serial therapies. And you can see the difference between the pre-treatment and the post-treatment. You get involution of the bone around it. If on the follow-up treatment, we've still got areas that have got fluid levels, so they're still producing an aneurysmal bone cyst component, we'll suggest a further sclerotherapy. So overall, like I said, there's an increasing need for all of these types of services, particularly in the paediatric side as well. It's amazing what children can manage, and certainly in our practice with both our adult surgeons and our paediatric oncology surgeons, we've moved away from doing open biopsies in a lot of these patients and moved to percutaneous work. A lot of that came out of the pandemic and access in general to difficult things, and general anaesthetic is difficult to get access to, particularly even as a radiologist. But there are ways that you can utilise your services and expand them in the percutaneous radiology side. So that gives you an idea of some advanced imaging, where the imaging can help, why we're doing it, cases where it makes the difference, and areas that you might think about how you could work and utilise your own radiologists and try and increase their expertise in some of these areas if it's not available. So thank you for your attention. Any questions?
Thank you very much for this very interesting talk and educational talk. I've had a couple of osteomas occurring in the spine, very close to the canal. Are you people injecting cooling agents and still resecting them by means of your intervention, the radiofrequency intervention?
We would actually still ablate them. There's only one spine osteodysteoma we have refused, and that was in the tip of C2, so we couldn't access it. But yes, we are ablating these. All we're doing is we're changing potentially how long we do it for. So it may be it has to have more than one session, because when it's close to things, because of the degree of heating around it, instead of going for, say, 6 to 9 minutes, we'll drop to 3, we'll do it at a few more buzzes, but we'll know that there have to be a second session and see how they get on. So we'll just change our technique a little bit, but yes, we still do them, or there are very few we don't do nowadays.
What about your recurrence technique by decreasing the dose?
Correct. So exactly. So we have to have that in mind. So we would do normally a very close follow-up on it to then plan for a second ablation sitting. And we always tend to warn the patients there may be more than one procedure with these, particularly the larger ones, the ones that are more like osteoblastomas. We commonly tell the patient this will be more than one, so that they know. So we tend to say that because of for safety reasons, we can ablate, but we can't necessarily ablate at the 9 minutes we can for something, say, in the tibia that's in a much safer position. But yes, we do all of them.
Okay, can I ask one more question? How quick can you provide us orthopedic surgeons with a diagnosis with the help of a radiologist on taking a core biopsy from a lesion? And how would you do it? Would you take it at the periphery? Would you take it at the center? How many specimens would you take? And thank you.
So, like I said, we do a direct access for our surgeons on the day. Our surgeons will see a lot of their patients and send the patients literally around the corridor to us. We have dedicated slots. Our core biopsies on the Monday our pathology lab is literally one floor above us. We will all take anywhere between 4 to 6 samples. Generally, if it's a very large tumour, I tend to have the rule of a clock face. In other words, try to take samples from the representative around it. If on ultrasound you have some Doppler vascularity, then that's normally an area that's more likely to get you the higher grade area, so we'll target that. So we're not afraid of areas that look like they've got a lot of blood vessels in them. All bleeding, I believe, stops with pressure once I've got the samples. From the point of the sample being taken, it will go up to the lab, and the diagnosis will generally be by the end of the week, if not for the Monday MDT. So Monday biopsies results on Monday morning. And so we have direct access for ultrasound-guided biopsies, and we have some possible access to MR on the day as well.
So I see. But you go through the same percutaneous route. You don't use many to get them.
No, so what we tend to do is we go, obviously we work closely with the surgeons as to what area they want us to particularly approach in. It's their approach, not the one that I prefer. We will use what we call a coaxial kit. In other words, I will put something in that stays in, and I will go in and out of that, and I will simply change the angles on that one piece of kit whilst it's in the tumour, so that we only make one small nick. And it really is, it's like a 2 millimetre nick in the skin and 5 mils of anaesthetic. It's amazing what you can do, even to children.
Thank you.
Hello, Karen.
Hi, Max.
It's Max Gibbons here. Thanks, Karen. That was a very nice overview of current concepts. One thing you didn't touch on was that it shows how important it is that the radiologist and the pathologist we work together. And certainly over the last 25 years, practice has changed a lot. For example, you now treat a lot of our osteoid osteomas, and as you see with the sclerotherapy, a lot of the aggressive pediatric benign tumours like ABC. But also, I've seen over the last 5 or 6 years is that we no longer treat the benign soft tissue vascular tumours. It's generally your province. Could you just give a comment for our Tunisian colleagues here, because they'll see a lot of that?
Yeah, so obviously we're taking the ABC work, the sclerotherapies, but we're talking for some of the benign work, but still needs treating. So, for example, the reason we're talking about ultrasound before versus low flow and high flow vascular malformations, the idea is if something's got little cystic spaces on it, that you could actually almost block them. So some of our interventional vascular radiologists are also using sclerotherapy for all of our vascular malformations as well. So we're injecting a kind of like a sclerosing foam into it, which therefore shrinks it. From an imaging point of view, we can see whether they actually are viable or not. So, for example, some things like low-flow hemangiomas can sometimes be more soft tissuey than they are cystic spaces, so are not really amenable to these type of techniques. But when they are more cystic spaces, then yes, that's areas that are also pretty much taking over from the radiology point of view. And I agree. I mean, the pathologists come down to talk to us when they've got difficult cases that they're looking at. They come down to talk to us with the radiologists, mainly so that we're all putting out a joint diagnosis, because it's not just one person in isolation, it's all of us as a group, from the surgeons to the pathologist to the radiologist. It is one big MDT.
And, following on from that as well, Karen, is that you have reduced our work a lot, because you see in the clinics every Monday the large soft tissue mass, the metastatic mass in bone. The biopsy is critical, and quite often it comes back as a lymphoma, and that is not the orthopaedic surgeon's province. And equally is that the point that you made very clearly, we have this in clinic, you do that, pathology, we have the answers back immediately, and these patients get treated swiftly, often without the surgery.
Yes.
Yeah. Well, many thanks.
Okay, thank you. I would like to thank you for this is very nice, interesting talk. I'm Dr. Hassan from Sudan. I'm orthopedic oncology surgeon. I would like to ask about fibromatosis, because this is the small tumor. I hate it because whatsoever you do, it's going to recur. And one day, before 10 years ago, when I come back from my fellowship, I used to do wide resections, but unfortunately, it recurs for many times. And I would like to know whether there is any predictions for what is going to recur after your radiology or in the MDT meetings in Oxford. What do you come to, if there is any consensus about it, because I know there is a lot of controversy in managing those type of tumors, the small tumors especially. So if you can give a comment about that. Thank you.
So I'm sure the guys can comment on the surgery. We try not to touch them if we try not to. We tend to use medical oncology. So obviously, with the first question everyone will ask the patient is, are they on the oral contraceptive pill? is one of the things. The other is our medical oncologists use things like tamoxifen for them, and we use MRI to look at the response. Like we showed you some of those cases there, there's change in signal characteristics when these patients are on certain medications that you can see a response to therapy on them. I'm sure Max is not keen on resecting fibromatosis. Most surgeons aren't. And normally they're either followed up routinely on MRI with us or followed up whilst under medical oncology, who treats most of them nowadays.
Thank you.
Yeah, I think usually we stopped operating on fibromatosis unless it's a lesion that's in an anatomic area, for example, in the buttock and the patient is finding it difficult, or in the foot that's really painful and has not responded to medical treatment. That will be the only scenario where we would resect. Any comments from Duncan?
I don't think I've operated on fibromatosis for 10 years. I did like you. I did a few maybe at the start of my career and quickly learned you try and not operate. So yeah, that's absolutely categoric.
I think that's about it. Karen, thank you so much. I understand you have to go and catch another meeting. But thank you so much for taking the time out. And it was a narrow window. Thanks so much.
All right, thank you.
Bye-bye now.
Right.
So we have...
So we will start the case session. We have 6 presentations per 60 minutes. So I will ask the speaker to respect the time, 10 minutes per presentation, and we will start with Dr. Nouri with the first case. Yes, yes. I will ask Dr. Bozidi to... Yes? All the moderators. Dr. Fakhreddin. Dr. Nouri, you present and... Comme présentation, vous êtes modérateur.
Okay. Let's go. Okay, it's a 26 years old female who presented with 3 years history of progressive stiffness of the right knee. She hadn't any pain, and these are the X-rays of the knee. Is it interactive, or I should interpret myself the X-rays? Okay. What do you think about these X-rays, AP and lateral view? Who wants to interpret?
I think we can have the mics passed around the participants. We'd really like to hear participants' responses on this, and then the faculty can obviously add from their input. Does anybody want to take this X-ray?
Simple question. Is it a surface or intramedullary lesion? Okay.
You don't have to speak in English.
So it's a surface lesion. Is it a soft tissue lesion or a bone lesion? What do you think? Is it a bone?
Somebody wants to answer?
Okay.
I believe there are microphones around the hall. Should we just pass it to the... Please go ahead.
Okay. Looking at the site of the lesion, first of all, it's a metaphyseal lesion. Second of all, you look at the lesion, it's mainly blastic, so it's an osteoblastic lesion. Now, the history, you say 3 years she's been complaining of pain. Now, the only lesion I can think of, which is malignant from one side, or a benign from the other side. Malignant, I would think of a parosteal osteogenic sarcoma. Many times a parosteal osteosarcoma occurs on the surface, but it's a slow-growing lesion. and it penetrates the cortex, and it can enter the medulla. Now, on the other hand, it's far from being a myositis ossificans. I cannot think of it, and I cannot think of any other soft tissue lesion like this, and it seems to be closely attached to bone. So that's my diagnosis. Thank you.
Okay.
I think what we want to try and break it down is that's not got rings and arcs. That's not a chondroid matrix, so you can discount that. That's not lytic, so that's not a big hole in the bone with destruction. So that's quite clearly bone being formed, as we said. It's a disordered osteoid, disordered bone being formed here. Key thing, age. Growth plates are closed. That's a slightly mature. That's not. We're not in the pediatric, maybe Ewing's or central osteosarcoma. A bit older, etc., slightly mature. And site, metaphysis. All these clues that you can just be talking about for a minute easily should come out, and that will slowly, as we said, start to give you a few differentials. Infection is a really common differential, and we see it in my country and you see it in your country. Could that be infection? Yes, infection can masquerade in many ways, as you know. So you can often bring infection into it. Fibrous dysplasia with its sort of ground glass matrix can often sort of be a bit disordered as well. So sometimes you can bring that into it. So already you've got a bit of a differential here. The question is, yeah, it's a bone-forming tumour. It's aggressive to a degree, but there isn't a soft tissue mass, is there? There doesn't seem to be a big shadow around the tumour with a soft tissue component. So that gives you a little bit, that's something else to describe, but that gives you another little bit of information. So yeah, I think you can't quite tell whether it's surface until you get cross-sectional imaging, but you can certainly start to bring that into your spiel. So I've just spoken for 2 minutes, relatively easily, just with some of the X-ray findings. And for the residents in the room, that's what we want you to try and talk about. Age, site, and some of the matrix, and what's happening to the bone, and what the bone is doing to the tumour.
So, yeah.
Dysplasia. I don't think it's related to fibrous dysplasia. I would disagree with you concerning this. Fibrous dysplasia, I wish we would see so much bone in fibrous dysplasia. The problem is we have lack of bone. You see, so I agree with you, everything with what you said, but the fibrous dysplasia will tend to be an issue.
It wouldn't be at the top of my differential, but I've had cases of fibrous dysplasia with expansion. In fact, I did a proximal tibia only a few weeks ago with a big expansile mass outside.
Was it blastic? Was it blastic?
There was some elements of plastic. So it's not my top here because there's a big soft tissue extension. But normally, if you didn't have the expansion, I'd bring that in. Okay. But you could.
Thank you.
I thought you beautifully described the site. It's distal femur, surface tumour.
Exactly.
It's aggressive. This is going to be a surface osteosarcoma.
It's
classic
very
age.
simply.
But you're quite right. There are the rarities.
Yeah, I agree with him.
You know, like meloriostosis.
There are weird cases. Yeah. We have to admit it.
But this is a difficult problem where it is, and with regards to neurovascular structures and what.
Thank you.
If we try to describe this lesion, it's a surface lesion. It's a melon-shaped lesion. It's dense. It's pasted on the cortical bone, from which it is separated from a radiolucent line that we can see clearly, especially anterior aspect of the cortex in lateral view. So if we sum up, lady, 26 years old, distal femur, surface lesion, melon-shaped, dense, radiolucent line, I think there are not many diagnoses to consider, and the first of them is,
surface
parietal osteosarcoma. The first diagnosis to consider. Next slide. Next. It doesn't work. Please.
You don't need any more imaging.
Yeah, we need more imaging, especially for the local extension of this lesion. And we have the MRI, and on the MRI we see clearly that the lesion is on the cortical bone, but there is a focal involvement of the medullary canal. We can also, the image in the middle, we can see what we have in X-ray, the radiolucent line. We can obviously see that the lesion develops on the surface of the periosteum, the outer layer of the periosteum. And once again, the focal invasion of the medullary canal. So it's more likely parosteal osteosarcoma.
Yeah, so I think a good point to raise at this is obviously the importance of cross-sectional imaging, which actually shows you the whole size of the tumor and where is it arising from. As you can see, it's mostly medial and then also going around the posterior medial corner. One more thing to pick up here on X-ray and MRI is the periosteal reaction. So for a classical osteosarcoma, you would have a very interrupted periosteal reaction, which is pathognomonic, such as a sun ray appearance, whereas in a surface osteosarcoma, there is a Codman triangle, but it is a very solid periosteal reaction, and that shows you that the tumor is a slower growing tumor as opposed to a classic osteosarcoma.
So what is the next step? Biopsy, yeah. Who goes for a resection or curettage? No, biopsy first. Next, please, next slide. So on biopsy, we observed a bone-forming tumor, a well-formed bone trabeculae, mature bone, the osteoid, with the fibrous cell stroma. And these are features of a low-grade osteosarcoma.
There is component of cartilaginous in this tumor, and this feature avec atypical cells is not seen in low-grade osteosarcoma. D'accord? This is osteosarcoma. With correlation with imaging, this is for probably periosteal osteosarcoma, but we don't conclude as low-grade osteosarcoma in this feature.
Because they are well-formed parallel bone trabeculae.
In low-grade osteosarcoma, ATP are very few, and mitotic rate is very low. This feature is not a feature of low-grade osteosarcoma.
Okay. I think what that comment highlights is how important an MDT is. So you have to, so purely on that slide, your pathologist might not be able to reach a diagnosis of low grade. So it's always correlation with your radiologist and with the orthopedic surgeon, and obviously with the presentation of the patient, that will all add up to saying that whether it's a low-grade osteosarcoma or not.
Okay. Next slide.
And if I can also just emphasize that sarcomas don't read textbooks. And we have both lectured and largely said that periosteal is low grade. We have seen higher grade, absolutely. So you don't read textbook, you have to go on this collaboration between pathology, radiology and surgeons.
Yes.
It's interesting, but
very important.
Exactly as you described, we'd say as a surgeon, well, that looks low-grade-ish to me, but they never behave that way, the surface osteosarcomas. Just a rule of principle, we generally treat them all as high-grade regardless, but it's a really, really important point you made. Yeah.
Okay, next slide, please. So we have concluded to a parosteal osteosarcoma, which would be more likely differentiated. We have resection of the distal femur, and this is the macro section of the specimen. And on histology, we find two components, one on the right side with a low-grade osteosarcoma with a sharp transition with the second component, which is in the left side with a high grade. And we see this transition between the low grade and the high grade, and this is the signature of dedifferentiated. And in dedifferentiated parosteal osteosarcoma, we observe the two components, the low grade, which is the classic parosteal osteosarcoma, and the high grade, which is of the dedifferentiation. Any comment?
This feature is not characteristic of the differentiated low-grade osteosarcoma, and we must do the immunohistochemistry for MDM2. MDM2 is characteristic when it is positive. This diagnosis is correct. If MDM2 is negative, this is not a diagnosis of the differentiated.
How can you describe this component on the right side?
Right side, in well-differentiated osteosarcoma, the tumor produces mineralized osseous matrix. Here we have osteoid matrix. Yeah. Osteoid matrix is extremely rare, observed in low-grade osteosarcoma.
Okay. So
this feature
what is your diagnosis?
Is not characteristic of low-grade osteosarcoma. In my sense, we do the immunohistochemistry for MDM2. If it is positive, your diagnosis is correct. If MDM2 is negative, this is not the diagnosis of the differentiated osteosarcoma, so low-grade osteosarcoma.
So this is a high-grade osteosarcoma on the surface of the bone?
That may be periosteal osteosarcoma. It is possible.
It's
but periosteal osteosarcoma is different of parosteal osteosarcoma.
It's chondroblastic, the periosteal osteosarcoma.
Oui, mais here this feature we haven't the chondroblastic component, but
okay, but we have all the specimen and we analyze.
It is very simple.
No, here just a sample of the histology.
It is very simple. You must do immunohistochemistry for MDM2.
Okay.
For the correct diagnosis of the differentiated.
But when we have a perfect concordance of clinical, radiological, and histological features.
I think as far as dedifferentiation and all of those are concerned, we'll just have to, I mean, usually we would just rely on our pathologists and take their word for it, because they obviously, and I do agree, it's MDM gene amplification, which has to be there before calling it dedifferentiated. If you haven't done that, then you cannot technically call it dedifferentiated. But I think, yeah, it's a parosteal surface sarcoma. We've done the right operation, and how has this been reconstructed?
Megaprothesis, but it's not the scope for surgery. It was more about to describe the lesion. That's why I didn't present the resection.
I think we have to go back before we do about the surgery and talk about chemotherapy. So that's a discussion we would have had. Was there a role with that biopsy, with that histology, that's a bit more than a low-grade parosteal sarcoma, a role of neoadjuvant chemotherapy, knowing that on the whole this is still a systemic disease rather than just a local sort of distal femoral issue?
I will give you the answer. Okay, we have published a paper about surface osteosarcoma, and the parosteal osteosarcoma is the most common subtype, even though it remains rare, less than 5% of all osteosarcoma. The mean age of patients was about 25 years, and the females were more presented with this lesion. And it's a slow-growing lesion. It can remain asymptomatic for many years. The classic partie osteosarcoma is a lesion.
As you see here, this is the feature of low-grade osteosarcoma. This is microscopic characteristic of low-grade osteosarcoma. You see the osseous trabeculae?
I showed only a sample. I didn't. I don't have all the slides. I can give you all the slides if you don't agree with the diagnosis. This is only a sample, and we examined the case with the pathologist and all the slides.
Can you go on? Because
yes,
there is
of course. Yeah.
We are waiting.
So the classic
low-grade,
the classic partie osteosarcoma is a low-grade tumor, fibroblastic, and sometimes it gets the differentiation, as we saw in the first case. The two other subtypes are the periosteal osteosarcoma, which is a rare lesion on the surface. It is mainly chondroblastic, and it's intermediate grade of malignancy. The third subtype of surface osteosarcoma is high-grade surface osteosarcoma, which is also chondroblastic, but with a high grade of malignancy. And usually we have intramedullary involvement in high-grade surface osteosarcoma. So in summary, classic partie osteosarcoma is the most frequent subtype of surface osteosarcoma. It's a low-grade tumor. When medullary canal is involved, the differentiation should be considered. Treatment is wide surgery. Chemotherapy should be used only in high-grade surface osteosarcoma and as adjuvant, not neoadjuvant. And these are the results of a study from the Rizzoli, who showed that these lesions are not sensitive to chemotherapy, and the lesion can even progress under chemotherapy. That's why we have to go to surgery immediately and propose chemotherapy in high-grade cases.
Thank you.
Thank you.
Thank you, doctor. Thank you very much. We'll invite the next case, please. It will be.
We'll invite Dr. Yusuf Othman.
Please, Yusuf, try to manage time because we have too much cases
Okay.
to present next.
So thank you. Good afternoon, everybody. This is case number 3, yeah? Okay. I'm Yusuf Othman from Monastir, and I would like to present to you this case about an unusual aggressive pelvic tumor. So it's about this 20-year-old male with no relevant medical history who presents with this mild breakthrough mechanical low back pain. It's mainly in the left side, and it has been evolving for 3 months. No trauma history, no fever, no loss of weight. And on physical examination, we found this ill-defined swelling of the low left paravertebral region, which is painful at palpation, fixed to the underlying tissue. Hip range of motion was normal, there's no limping, and we explored this patient with this AP pelvic X-ray, and it shows this osteolysis of the iliac bone, the left iliac bone. It's a Ludwig 1C type osteolysis, which involves the iliac bone. It's transpassing the sacroiliac joint, and there is a cortical break in the posterior iliac crest. No calcification and no periosteal reaction. So at this stage, the diagnosis of a pelvic sarcoma is highly suspected, and we needed further investigations in order to find more about this lesion. So this is the MRI. This is MRI, and so this lesion is tisular, aggressive, with big dimensions, and it is invading both bone and soft tissue with the gluteal muscles, iliopsoas muscle, paravertebral muscles, and ilium sacroiliac joint and the sacrum. It involves mainly the sacrum with a hazard for the roots. So there is a central hemorrhagic zone with the T1 hyperintense signal. Scan did not show any metastasis, and it further shows the involvement of bone and soft tissue. So at this stage, we needed a surgical biopsy, and the histology findings were a giant cell tumor of the bone with a secondary ABC, aneurysmal bone cyst. Regarding the cortical effraction and the soft tissue invasion, Campanacci 3 lesion. So for our patient, regarding the location, the proximity of the sacral roots, the size of the lesion, we proposed the donizumab treatment with the classic protocol, and it was we gave him donizumab for 6 months. And clinically, the patient is doing well now with much less pain. These are the 6 months follow-up CT scan, which shows a mild regression on the size of the tumor, which is now more clear, more identified. And at this stage, we're asking you, we want to discuss with you, what is the next step to do? Should we do an anti-tumoral curettage, maybe with an adjuvant treatment, or do an en bloc resection with reconstruction? Or should we consider that our patient, this tumor is still hazardous to resect, and just to go with the long-term denosumab? So let me present you some literature data in order to start the discussion. A few studies compared curettage versus resection in patients receiving denosumab preoperatively. This is the study 2018, 89 patients, and we note that the resection group is doing much better in terms of recurrence. But it's not widely admitted. For example, this meta-analysis with 10 studies, more than 1,000 cases, it talks about the higher recurrence of higher risk of recurrence with denosumab, but only 4 studies performed analysis in subgroups comparing resection versus curettage with no significant differences. So the last option may be long-term denosumab, but as Dr. Sadiqi said earlier this morning, denosumab does not treat the tumor. It's not active on tumoral cells. So once we stop it, the disease progresses again. And this is what shows this study. It was presented by Dr. Sadiqi this morning also, but it's just for the 20 patients who stopped at denosumab for different reasons. 10 were lost on follow-up, but 4 out of 10 had a tumor regression when they stopped at denosumab. So is it an option for this patient? And I would like to hear you about what we should do next.
So yeah, so I think we have got some sacral GCTs that we have maintained on long-term denosumab, and it will be lifelong. And that's just because the morbidity of doing a sacrectomy is enormous. The morbidity of doing a surgical resection here is not enormous in this case. It's a type 1 pelvic resection. You can reconstruct it relatively well. You can keep the abductors reasonably well maintained with the superior gluteal nerve intact. So you should get some reasonable function after it. So there's no doubt about it, the surgical resection has more advantages, I think, than long-term denosumab in this situation. But obviously it's very different once it goes into the sacrum with the nerves, etc. So yeah, we would probably do exactly what you've done. You've nicely hardened the tumor. It's easier to manipulate. You can see where the margins are now, and we would do a relatively close margin resection, maintaining the abductors, and then the denosumab can stop.
Yeah, I think I would actually just echo that, but coming back to those papers, these were the exact papers that I showed on my presentation earlier. The problem you would have if you were to consider the third option, which was continuing with denosumab, again, you don't know the answer of how long. Yes. What will the problems be? It's a young patient, 20 years old.
Yes.
How long are you going to continue? When are you going to stop? What will you do if they get a recurrence? those are all very complex answers to get. And in this condition, in this situation where you can get away, you know, with relatively simple surgery, you're not reconstructing the hip joint, you're not managing a very morbid area. It's a PSIS tumor mainly, so it's a type 1 resection, which is, you know,
feasible,
reasonably manageable, and I would actually also just go ahead and resect it. I think that's probably the right thing to do.
I don't think the question is
intralesional. After that much hardening, if you do intralesional, you definitely get a recurrence.
Yeah, I think intralesional here, yeah, it will come back. So I think we go for an en bloc in this situation. But the reconstruction would be to try and restore the pelvic ring. I think the pelvic patients with an intact pelvic ring are more comfortable. They don't get the shortening as the pelvis sort of rotates. So we would do a reconstruction with a vascularized fibrillar graft in place of where the ilium was.
So thank you. Now I have a clear answer, and that's why I will show you the beach of Monastir.
Thank you. Excellent case.
Thank you.
Excellent case.
Well, I'd like to thank the organizing committee for this opportunity, and especially Dr. Tricky, Fakhreddin Tricky here present, as I'm presenting his case, and I'm doing so probably because I speak a slightly better English than his. So I'm going to present his case that he has done along with Dr. Jlidi here present. So our case is about a 44-year-old woman. She has 2 kids. She's pregnant on her 26 weeks. And she has a painful shoulder with a widening of with left shoulder and limitation of mobility. She consulted with this X-ray, and you can see this very aggressive the tumor that we have here, confirmed later on by the MRI. It's aggressive, it invades the shoulder, the upper head of the left humerus, and that's why we decided to go for the CT-guided biopsy for this case, and that's what we found. Dr. Jlidi?
And in this core biopsy, there is microscopic features characteristic of conventional osteosarcoma, with production in these sarcomatose proliferation of matrix osteoid on Miralli's osseous matrix.
We knew that from the X-ray, though, didn't we? Just go back to the X-ray. Let's just really re-emphasize that X-ray.
Starting from
we knew that, didn't we? Bone formation, yeah, sunray spicules, Codman's triangle. We knew all that, didn't we?
Yeah.
You just confirmed it.
But the biopsy is, we have to do it.
You have to do the biopsy, but it was just lovely to see the X-ray. Very classic. Yeah.
Okay. So we are facing an osteoblastic osteosarcoma, upper head of the left humerus, 44-year-old woman, and she's pregnant on a 26-week. So for that reason, we couldn't have the extension assessment for this patient, and we were facing 3 scenarios. Either go directly for the surgery, or go with a therapeutic abortion, then go with a standard treatment with chemotherapy and surgery, or start with chemotherapy with maintenance of pregnancy, and have a good talk with the mother with the risk of fetal toxicity. So after discussing the case in the multidisciplinary team and even with the family, that's why we decided to go with the third option. She was already aware of the risks of the chemotherapy, and that's why we decided to go for the right option. So it went with the 4 cycles of chemotherapy. 3 cycles went so far so good. We even noted a decrease of the size of the left shoulder. And on the 4th cycle, which was 2.5 weeks before the planned childbirth, which was the planned C-section, the mother started to have contractions. She was carried in emergency room, and we were expecting the worst for the baby as we were having the decrease in the heart rate. And finally, we'd have a beautiful baby boy. Well, in that moment, that's where we're supposed to go, oh, that's cute, but we're orthopedic surgeons, right? And she was doing good. She was doing good as well as her baby, fortunately for her, and we were able to assess afterwards the chemotherapy effect. We start to have the osteocondensation of the lesion, and on the MRI, we noted that there was no increase in size. and we started to notice even the necrosis. So we were able to make the extensive assessment, with the CT scan was normal, and the bone CT scan, unfortunately, we were having this lesion. It was another lesion which was localized in the left head and neck of femoral neck, confirmed in the MRI and the CT scan, which we used to have the surgical management. So we decided to go for this patient with the anterior approach. Started with the femoral neck and head, made the resection, replacement with total hip arthroplasty. And this was the piece with the which was divided later on. You can see the tumor. For the humerus planification, we decided to go for the fusion of the shoulder, and it was made with a wide deltopectoral approach, and the cavity was filled later on with the wires and the cement. And this was the lesion. You can see how it looks really aggressive. And these are the X-rays after the surgery. You can see that it looks good. So far, so good. And when we made the pathological exams, we noticed 60% of necrosis in the left femoral neck and head, and 80% of necrosis for the humeral part of the tumor. So we decided to go for another 2 rounds of chemotherapy for this patient. And at the end of the chemotherapy, she had a good function at the end, but we had to go for the reconstructive surgery. So that's why we to go again with the deltopectoral approach. You can see the plate. You can see the plate that we have there. That was a customized plate for this patient to make the shoulder fusion. We used non-vascularized fibular graft associated with cancellous bone graft, and this is the radial nerve looking good, and that was confirmed later on with no nerve palsy. This is the X-ray for the patient, and that's the function she has 2 weeks later on. You can see that she has a small movement of abduction through the scapulothoracic articulation now. We were following the patient after on with the X-rays, but afterwards we started to notice that we have here an osteocondensation in the distal humerus. If you make the comparison here, you can see that there is a osteocondensation, but we were reluctant to go again for the surgery. So after more X-rays, followed by few months, even the MRI didn't show anything suspicious, and the ultrasound didn't show any suspicious mass. So we decided to wait and see. And afterwards, I think there is no more hesitation. This is speculated reaction around the tumor. So we had to make a CT scan, and it confirmed that there was another tumor here in the distal humerus. At that point, we were questioning ourselves, did we really miss escape metastasis? So that's why after seeing again the first MRI, there was no lesion at that time, and even the bone CT scan didn't show anything suspicious at that time. So the complementary assessment were fortunately negative for this patient. That's why we are facing a recursive tumor following 1 year at the end of the treatment. So we had to go on again with the surgery, take off the plate, the whole plate as is contaminated, let's say, with the tumor, and take away all the distal humerus, and this is filled again with the cement, and this was a piece of resection for this tumor. And this is the X-ray after the surgery. So what did we find here?
Here, as you see, there is aggressive distal humerus tumor with extension in soft tissue, and histologically, it is osteoblastic osteosarcoma with 3 patterns, and the left top osteoblastic osteosarcoma, conventional, on right top epithelioid sarcoma, epithelioid osteosarcoma, and the left low you have small cell component in this osteosarcoma. Doesn't work. Here. And this sarcoma is very extensive in small in soft tissue, but the resection is complete. with marge superior to 2 millimeter.
Okay.
With this 3 localization of the osteosarcoma, 2 in the humerus and 1 in the femur. And there is no metastasis, no long metastasis in these 3 situations. And by definition, multifocal osteosarcoma is osteosarcoma in different sites without long metastasis. This case is multifocal osteosarcoma with 2 localizations in the humerus and 1 location of the femur.
Without metastasis, hopefully, for this patient. But after discussion again, the multidisciplinary team decided to go again for the chemotherapy here. And after 2 sessions of chemotherapy, she had to go again for the surgery with the reconstruction time. We had to go again with the other non-vascularized graft, make a reconstruction of distal humerus, and make a harvest of hamstring grafts from the leg that were used later on as the lateral and medial ligaments for the elbow, and they were fixed through this custom plate. And when we had to take again, the cement has to go again, and this is how it looks like after the reconstruction part. And you can see the functions that were assessed during the surgery of this newly made biological elbow, let's say. And this is how it looked like in the X-ray, going from the scapula to the distal humerus with the elbow. And how is she going today? Well, hopefully she was able to keep her baby, and he's a fully grown baby boy. And even though she had the skin necrosis after the left surgery followed by the flap, she still has small function of the arm like she had around here. And fortunately, that's an arm that she can feel and carry her baby on with, hopefully for this patient. So what we have to keep in mind, well, the importance of discussing these difficult cases in the multidisciplinary team, and especially the family. And recurrences are difficult to take care of, but we have to keep in mind that be patient all the time with these recurrences, because patience is a virtue. And thank you for your attention.
Yeah. When should we, I want to ask the group, when should we give up and perform a 4/4 amputation in this patient? Please help me.
When we retire. En retraite.
The limb salvage is all about whether it's going to be a viable arm or leg afterwards. Now, there's difference between the arm and the leg, isn't there, in terms of mobility?
I know, I do agree, but at the risk
what you mustn't
of the
do,
life of
I
the
think,
patient.
What you mustn't do is compromise on oncology. That's you've got to get it out and get that clear margin, etc. Now, if that requires that you're going to lose a nerve or lose a sort of vascular supply, then you do. I don't think we do give up. I do think that we are very aggressive in osteosarcoma. I think it's the evidence is that you should keep taking out metastasis. You should still be aggressive, etc. But of course, there is a time where the patient sort of and we sometimes have to have ethical meetings where us as a surgical team need to meet up with lay people, just so, because we often are very much sometimes emotionally invested in patients' care, and sometimes to get a sort of a layman's view, really. This is why this whole area of orthopedics is so interesting, but also quite challenging. It's this whole aspect of the emotional side, and we have about 2 or 3 pregnant cases every year, and gosh, they're difficult, really difficult. And to start chemotherapy at 26 weeks, I don't think we would do that, would we?
No, we try and wait till 30 weeks.
So the fact that you have done it successfully,
well done.
Interesting. Yeah, we haven't done that yet. We've always tried to get the baby delivered early, and then the mother starts. Unfortunately, we had a death last week, didn't we? A mother, unfortunately, died a week after diagnosis, but the baby was born by cesarean.
So I know we are running over time. Sorry, can I just ask one question, actually? How did you get so much fibula?
So much fibula? Well, you
So
can
the first
ask.
reconstruction was fibula, the second reconstruction was more fibula. How many fibulas did she have?
Well, she has two. She has two, but very long ones.
That's still a lot of fibula from both legs combined.
I have a comment, not a question. I think that the association between the pregnancy and the cancer is not.
Sorry?
I think there is the association between the pregnancy and the cancer is not by chance. There is a relationship between both. We observe a lot of malignant tumors that arise during pregnancy because there is a decrease of immunity and the increase of the growth factors. And this association is well described.
Yeah, I think you're absolutely correct there. I mean, we had a very similar case this week, and the mother decompensated very, very quickly and died. But baby was delivered at 27 weeks successfully. And yeah, well done, that's remarkable. But I completely agree, it's a multifocal osteosarcoma, isn't it?
Multifocal, yeah.
So she'll survive.
Yeah, exactly. Thank you. Okay, shall we go for the next presentation? Yeah.
Next.
So,
Good morning, everybody. So I will tell you a story of this case. This 17 years old girl, beautiful girl, she went to her family doctor because she was complaining of right hip pain since almost 6 months. And her plain X-ray radiographs showed this mixed lytic and sclerotic lesion around the posterior iliac crest and on the roof, acetabular roof, for the right side. This is the CT scan, and this is the MRI done 1 week later, and showing this lesion. Focused on the posterior iliac crest and the acetabular roof of the right iliac bone. And the iliac bone seems to be involved, all the iliac bone seems to be involved when we see these lesions, but it's more important in the iliac crest and the roof, acetabular roof. Soft tissues seems to be conserved, and also the iliosacral joint and the hip joint, head cavity. So we did needle biopsy for her, and they concluded, the histopathologist concluded that it was a Ewing sarcoma. So it's a Ewing sarcoma, pelvis Ewing sarcoma, 17 years old. And when we did the general assessment, we find this metastasis. So we are in the case of Ewing sarcoma of pelvis, first presentation with metastasis. So they concluded after immunohistochemistry that it was Ewing sarcoma. And it was confirmed also later. Yeah. So in this case, what would you do at this stage?
We agree. We would want genetics as well. We would want the genetic abnormality as well to make sure it's Ewing's. And metastasis.
Yes.
So grade 3, sort of stage 3, we know the prognosis is poor, but yeah, it's neoadjuvant chemotherapy and see what happens.
So chemotherapy and see what happens for the lung metastasis. That's why. That's what we did. Chemotherapy, neoadjuvant chemotherapy, and lung metastasis seems to be good response, 80%. So for local control, you go for surgery or radiotherapy or definitive radiotherapy or both. It's a question, Habib. You talked about Ewing sarcoma.
It's a metastatic lesion. The surgery will be difficult. We have to resect part 1 and part 2, so the reconstruction will be very, very hard to do. We'll have worsen of
so you go for surgery?
No surgery.
No surgery.
High morbidity and low function result. So radiation therapy for local control.
I think we would agree. I think that's going to be a type 1, type 2 pelvic resection. That's going to be probably a hanging hip. It's going to be difficult to reconstruct. So I think chemoradiotherapy is reasonable in this instance to maintain local control of the pelvis. You might go for radiotherapy of the lungs as well to try and get pulmonary control. I showed a survival curve of Ewing's stage 3. Yeah, and it's not too bad. It's 20-30% sort of 5 years. So there may well be a reasonable sort of survival. But yeah, to go through a big pelvic operation, I don't think I would do.
Yeah, I think as a surgeon, the question you're answering here is,
yes.
Is your surgery giving the patient a survival benefit?
Yeah.
In this case, no.
No.
And a very morbid surgery with no survival benefit
is
probably of no use. And that's why you probably have to carry on with radical radiotherapy and then keep, exactly.
Anyone for surgery? The room? Dr. John? Yes, Adnan.
Well, I'll be honest. I agree totally with our colleagues of giving this patient chemotherapy and hoping for the best. But at one time, you might have to be forced to do surgery later on. But you say that the lungs are still infiltrated with the tumor.
Yeah, still.
So
no
we're not very justified with this. Okay, thank you.
Anyone less wise than that?
Someone had his hand up saying that what was that?
That opinion, Adnan. Yes, you can talk. I'm looking for...
If we are didactic, we must do surgery. It's Ewing sarcoma. It's normal chemotherapy, it's surgery and chemotherapy. And now, why not? Why not surgery?
Because poor prognosis.
Huh?
When we have poor prognosis, when we have metastasis at presentation.
But metastases are
Yeah, I think you can
discussion.
sometimes you can get complete response, and if maybe the patient had completely responded to chemotherapy and there weren't any chest metastases, then I would have given consideration to surgery.
In general, most Ewing sarcoma, essentially in young patients,
I think the evidence is that chemoradiotherapy is a very reasonable treatment for Ewing's, but the evidence is that adding in surgical resection does improve your local control. So what we've got to say, if the presence that the patients could still well have Ewing's in their body, what are we gaining by doing a surgical resection? So that's the decision here.
If we are sure that radiotherapy give control of the disease,
the evidence is, there is evidence that it can do.
We can't be sure, huh?
But
the
with less morbidity.
The answer is yes. Radiotherapy can have the same quality control locally as surgery.
Adnan, you will see the answer, and then I will continue, and you will see, because it's a really discussion.
I think if you review more recent literature, radiotherapy is now, it's a paradigm shift in treatment of Ewing sarcoma, and there are a lot of centers turning to radical radiotherapy as their definitive treatment option. And as I said, the question here would be that if you are going to operate, what is your intention of operating? Are you going to get her disease free? no. Even if she's got good response, she has an overall poor survival. So if you're not going to give a survival benefit from your surgery, what is the aim of surgery? What is the target of surgery? So that's the question that needs to be answered. And recently, a lot of, with protons, and then obviously with protons, obviously just increases the safety margin of radiotherapy. You can use protons if you have access to it. Otherwise, it's just radiotherapy.
Yes. So we were less wise than that, and we did surgery. We did hemipelvectomy involving the iliosacral joint and the roof, acetabular roof, and we did also the histopathology exams, analysis showed that there is complete response, chemotherapy response, and the limits, the margin are correct. So the reconstruction was fusion, femoral pubic fusion, maintained by double rod fixation with fibular femorosacral graft. And it was well done, and the patient came back 1 year later with a good fusion in distal part of the graft, but we worried about some lack of fusion in the upper part of the fibular graft, and we planned to make a bone graft for this problem. She was walking without any crutches. She has slight discrepancy, but not too much, and she was happy in her daily life. But unfortunately, lung metastasis again, and she died few months later. And this is the prognosis of this kind of surgery. So the question is, doing a surgery with high morbidity, with high risk of complications, for a survival rate almost near to the survival rate of radiotherapy control, would be wiser and better. So I agree with you now, after this, radiotherapy definitive for local control for this kind of surgery, and avoid surgery because there's no too much benefit for the patient. And thank you very much.
Great case, thank you. Oh, you've got a question, just you've got a comment there.
We have time? 5 minutes? 5 minutes. 5 minutes? Yeah, we have. There is case for 5 minutes?
Yeah, of course.
Yes.
I have a remark for our colleagues, orthopedists. For round cell sarcoma, now, in our Tunisian, we have all of what we need to have accurate diagnosis with immunohistochemistry and molecular biology. And we must have accurate diagnosis initially for the therapy strategy. This is very, very, very important.
Yeah, it's vital.
Last question. Yes.
We stop?
It's not a question, it's just a commentaire. We can't incriminate the chirurgy in that case. First, hemipelvic I do 20 years ago. Hemipelvic for Ewing sarcoma, and now the patient is free of disease, and it's all right. Donc we can't incriminate the surgery in this case. Not all surgery are bad on Ewing sarcoma. That I want to. We can just on one case.
I think that case clearly shows that the surgery didn't make any difference to the prognosis of that patient. And yeah, you can see that level of surgery is enormous. The time that must have to be an all-day case, etc. And the potential for complications was quite high. I think the patient could have probably had slightly better function with just radiotherapy.
See, but what surgery is good. It's only it's even good result, satisfaction. I want to see.
To talk to a surgeon, I've done 3 days in surgery doing a pelvosacrectomy. So yeah, we do it when the right indication. Absolutely, to have surgeons willing to take a patient and do big surgery for many days. Absolutely, that's what we need, I think.
It's a very fair point you made, but we discuss these cases at the MDT, and our cardiothoracic colleagues come in. We'd show them that chest and that patient, and they'd say, "We're not operating. Why are you?"
Thank you very much for the session. Just one point for housekeeping. People who don't have their lunch ticket, they go downstairs, they take their lunch ticket. For invitees, there is no problem. Go down to the restaurants on the left side on the mezzanine level. We will be back after 60 minutes, 1 hour.